Welcome, and thank you for joining us today for Putting Our Heads Together, Diagnostic Innovations for Alzheimer's Disease, part of our Value of Diagnostics Within Women's Health series. I am Irina Ninye, Chief Science Officer of the Society for Women's Health Research. SWHR is the national thought leader in promoting research on biological sex differences in disease and improving women's health through science, policy, and education. Spanning from simple blood tests to X-rays to invasive procedures, modern diagnostic tests and procedures are an essential part of clinical care, aiding in the detection and monitoring of diseases and informing treatment decisions. Innovations in diagnostics can provide access to valuable information to help make women make informed decisions about their healthcare across every stage of their lives. SWHR's Value of Diagnostics Within Women's Health series highlights the importance of advances in screening and diagnostic technologies, as well as approaches throughout the lifespan, with a focus on how we can improve health outcomes for women, particularly relating to reproductive health, healthy aging, and cancer. We're pleased to have two distinguished panelists joining us for today's public forum in recognition of June being Alzheimer's and Brain Awareness Month. Dr. Rachel Buckley, Assistant Professor of Neurology at Massachusetts General Hospital, Harvard Medical School, and Dr. Heather Snyder, Vice President of Medical and Scientific Relations at the Alzheimer's Association. I would also like to thank the sponsor of today's event, Roche. We will be live tweeting during this event and invite you to use the hashtag SWHR Talks Diagnostics and hashtag SWHR Talks Alzheimer's on all social media. Alzheimer's disease is the most common form of dementia among adults age 65 and older. The sex-specific underpinnings of this progressive neurological disorder disproportionately affect women, and especially women of color. Of the estimated 6.7 million adults in the United States living with Alzheimer's, almost 2/3 are women. Because there is currently no cure for Alzheimer's disease, early diagnosis is essential for slowing its progression, planning for long-term management and care, and maintaining quality of life for both patients and caregivers. The presentations today will highlight sex differences in Alzheimer's disease that can help to improve prevention, diagnosis, and treatment for women, as well as emphasize ways to empower women to adopt healthy habits that may improve brain health throughout their lifespan. I'll now introduce Dr. Rachel Buckley to talk about sex differences in the brain related to Alzheimer's disease and the value of diagnostic tests to support prevention and early interventions for healthy aging among women. Thanks for joining us, Dr. Buckley.
Well, thank you so much for having me, Irene, and thank you to the SWHR for inviting me to talk today. My area of research is very much in sex differences in Alzheimer's disease risk, and today I'd like to give a little snapshot of what we know currently and what we really need to know going forward in order to really think about diagnostics for the future. So what is Alzheimer's disease? I'll start off with the very sort of principal understanding of what we know about Alzheimer's disease as both a pathology, as in the disease in the brain, and also its manifestation. The two hallmark pathologies of Alzheimer's disease in the brain are amyloid plaques and neurofibrillary tau tangles. You can see both of these pathologies are shown here pictorially on the left-hand side. So while these both are pathologies that increase and encroach upon the brain for approximately 20 or 30 years, we also know that there is a manifestation of the disease as appearing as memory impairment. So we know that very, very early on, there are changes in memory and other thinking functions. And these will appear as what we call the dementia. But in fact, there are lots of different types of dementias, not just Alzheimer's, but also Lewy body dementia, frontotemporal dementia, vascular dementia, and others. In terms of how we measure Alzheimer's disease during life, we have multiple ways of approaching both within the body and also trying to understand memory and other thinking changes. On the left-hand side here, you can see there are two different forms of positron emission tomography scans. These are a way for us to be able to look at the pathologies as they appear and as they increase in the brain in humans as they are alive. So over here on the left-hand side here, you'll see an amyloid PET scan where you see colors that are quite hot. So anything from yellow all the way to red is showing a lot of signal of amyloid in the brain. This particular individual is someone who is actually healthy memory-wise. So they're showing no problems with their memory or thinking on pen and paper memory tests. But in fact, they are showing very hot colors of amyloid in the brain. On the second to left image, you can see a tau PET scan. And this is where you see colors from yellow all the way to red are showing more tau tangles in the brain. And you'll see that in this particular individual, this again is another individual who is cognitively healthy, so they show no memory impairment, but they're showing quite hot, vivid colors, mainly in the midline of the brain. And what we know about tau is that it doesn't tend to appear in the same areas as the amyloid. We also are able to measure now amyloid markers in the blood. There have been very recent and important changes in how we measure amyloid and tau in the blood. We can also measure changes of these proteins in cerebrospinal fluid using a lumbar puncture. And finally, we can also test changes in memory and thinking with cognitive testing. Most of my work focuses on positron emission tomography scans as well as cognitive testing. So I'll be referring a lot to that today in this talk. As Irene had already mentioned earlier in the talk, of all the people living with Alzheimer's disease dementia currently in the United States, approximately 60% of those are women. So we know that disproportionately women are affected by dementia, at least those who are living. In terms of death, we also know that mortality rates are higher for women. Mortality rates with dementia, whether it's a primary cause or a secondary cause, is also more likely in women than men, particularly at older ages, over the age of about 80. But something that's often not really considered or acknowledged is that women are also disproportionately affected by dementia in terms of caregiving burden. In fact, most reports, this one example here is in the Alzheimer's Association, show that women tend to be much more likely to be a caregiver of a spouse or other family member with dementia. And in fact, this particular piece of data that I'm showing here is suggesting that women who were working full-time are much more likely to convert to part-time work as a consequence of being a caregiver than their male counterparts. But there is an interesting component to understanding women's risk for Alzheimer's disease. There is a very, very strong genetic component to sex differences in Alzheimer's disease. We know that one of the strongest genetic drivers of the sporadic disease is apolipoprotein epsilon 4 allele, the ApoE4 gene. If you carry this particular variant, you are at higher risk of progressing to dementia later in life. And what this particular graph shows on the right-hand side here is that at a particular age in life, between 65 and 75 years old, if you are a woman who carries an E4 allele, you are much more likely to progress to the dementia than a man who also carries the same variant. This is a really fascinating finding because this age period, this 65 to 75 years of age, is actually a critical window for highest risk for dementia. And if you think of the age range at which it takes to start from the earliest signs of Alzheimer's disease, all the way to a dementia diagnosis, you're looking at about 20 years. And if you take 20 years away from 65 and 75, you get to 45 and 55 years of age, which is exactly around the age of menopause. And so I find this particular finding quite fascinating when thinking about what do we need to know to understand diagnostics and prevention for Alzheimer's in the future, particularly for women. In this particular example, I'm thinking primarily about menopause, and I'll refer to that in a moment. Now, when we're thinking about the disease, and I'm talking about the amyloid and the tau pathologies in the brain, we know that women do show differences in their levels of pathology than men, even during life, and even if they are performing entirely normally on memory and thinking tests. In this particular example that I'm showing here, this is a positron emission tomography scan of a group of men and women. Here, this PET scan is of tau only, not amyloid. And anything that you see all the way from blue all the way to a very hot red color is showing higher levels of tau signal in women relative to men. Immediately, what you can see on this scan is that there are areas of tau that is higher in women than men across a range of different areas of the brain. These are areas of the brain that are not just Alzheimer's disease focused, which this little tiny hot area here in the middle of the brain is usually what's considered to be the earliest spot for tau to appear. But you can see tau appearing higher in women than men across a range of different areas, which is quite fascinating to us. Alternatively, and by contrast, you don't see sex differences in amyloid PET scans. It's really in the tau. So if we're seeing these differences in pathology in the brain, in life, what does that mean for the manifestation of the disease? Well, these data here that you can see is looking at the level of pathology on the bottom here on this x-axis, is showing how much disease somebody has in their brain at post-mortem. On the y-axis, this is showing somebody's memory performance. So a higher number here is better memory performance. And what you can see on this particular graph is for a given level of very severe level of pathology at post-mortem, the cognitive performance was for women just prior to death was much worse than men, suggesting that at some point in the disease, women are really starting to show a susceptibility to the manifestation of the cognitive symptoms. And so this is something we really need to take into account and really need to think about when we're thinking of risk and prognosis for dementia. Now, as I referred to before, menopause is an area of great interest to my lab and labs across the United States. In particular, we're focused on the idea of when women might be going through their menopause onset and whether or not they might be undergoing surgery to induce menopause and whether or not they are using hormone therapy to treat menopause symptoms. In this particular data example that I'm showing here, our results suggest that those women who are going through post-menopause phase, so these are women who have actually now been a year out from going through all the sort of menopause transition of declining and ceasing menses, are showing much higher levels of tau on a positron emission tomography scan relative to men. These men are an age-matched group, so they should be exactly the same age as this post-menopause women group. And what you can see here is that these levels are very different. Women showing much higher levels of tau. This region that I'm showing here on this graph is an area in that midline section that I was showing you that is known to be very vulnerable to Alzheimer's disease, but we've actually seen higher levels of tau in postmenopausal women relative to age-matched men across many areas of the brain. But it's not just about menopause. The other area that I think that is really fascinating and needs a lot more research and consideration when thinking about sex differences in risk for Alzheimer's disease is the X chromosome. Now, the data that I'm showing here on the left-hand side is extremely complicated, and I don't really want to go too much into detail, but the takeaway point from this particular finding is that when we're considering rates of cognitive decline, so changing cognition over time in men and women, the X chromosome in women plays a very, very big role in whether or not women are more likely to show more risk for change in cognition relative to men. In the blue here, anytime you see blue with a whole bunch of numbers and letters, these are particular genes that are associated with protecting women from showing cognitive decline relative to men. And these orange lines here are actually showing a deleterious effect. In fact, these women who show or have gene expression on this particular gene are showing much faster rates of cognitive decline relative to age-matched men. And so I think there's an interplay between both menopause and the X chromosome to tell us a lot about women's risk for Alzheimer's disease. And I think this will have a big role to play in terms of how we think about prognosis and diagnostics. So let me just round out my area, my talk, in very briefly discussing what I think is the future vision and where we should be heading in research to think about women's risk and what menopause and the X chromosome might play in thinking about future risk down the line for Alzheimer's disease. On the top here, I really do believe very strongly that there is a role to play for menopause. It may not be drastically risky like some people imagine. It is not all women who go through menopause, because we know all women go through menopause. Not all women will be affected by menopause equally, and not all women who will be treating themselves with hormone therapy will be affected equally. On the bottom, we're also interested in the X chromosome. These two interplay, two factors are going to play a very important role to influence risk of pathology, but it will be through various pathways. These pathways involve risk factors that change very drastically post-menopause. So some risk factors that we already know change a lot post-menopause are metabolic syndrome, cardiovascular risk, sleep becomes very disrupted, and mood symptomatology increases a lot post-menopause. There is also increase for type 2 diabetes and other related factors. On the gene side, we know that the X chromosome is very heavily involved with neuroinflammatory pathways and the immune system as a whole. And we know that these two pathways are very strongly associated with risk for Alzheimer's disease down the line. So I think there is a very, very complicated story, a very interesting story to be told about women's health in relation to Alzheimer's disease. But we know that there are lots of unanswered questions at this stage. So I had referred to ApoE4, the ApoE4 allele, very early on. We know that there is an interesting connection between sex differences in Alzheimer's disease risk and the ApoE4 allele. The thing that we don't understand, though, is why. What is the underlying mechanism that might be driving increased risk in women who are E4 carriers? There's some suggestion that there might be an association with how fuel is processed in the brain or how lipids are processed in the brain. But this is still an evolving topic. On top of it, we don't fully understand how women across different racial and ethnic groups might differ in their risk and rates of progression to Alzheimer's disease dementia. This really needs to be understood further. On top of it, I've focused a lot on sex as a biological variable, but there are going to be a lot of other things that need to be considered when we're thinking about gender as a sociocultural and behavioral variable. Things like levels of education that were different early on in life or occupational attainment may also play a really important role. On top of this, and something that I haven't referred to, is earlier life course events, such as pregnancy, taking oral contraceptives earlier in life. All of these things could play a role and have been looked at, but need further investigation. And finally, there's a very interesting role to play for survival bias. And this is sort of a complicated point, but I do want to make it today, which is that women actually are very resilient. They live much longer than men. Across the globe, this is a well-known phenomenon that women outlive men. They also tend to live longer with dementia, with Alzheimer's disease dementia. There are also a lot of other very promising signs in the science to suggest that women are actually much more resilient cognitively than men, at least earlier in the disease. So at this stage, we need to understand, is it in fact that women are vulnerable to the disease? Or is it in fact that they are living so much longer and therefore have much more opportunity to show risk for disease relative to men? I think it's a nuanced point, but one that we should all acknowledge. And with that, I would like to hand over back to Irene. Thank you so much for inviting me to talk.
Thank you, Dr. Buckley. We really appreciate your introduction to this topic. And I do want to give a note to all those who are tuned in live that you can submit questions at any time using the Q&A function, and we'll try to address as many as we can during the panel discussion portion of this event. So next, we will have Dr. Heather Snyder, who will discuss gaps to address in Alzheimer's disease research and care for women. Welcome, Dr. Snyder.
Thank you, and thank you so much for having me. Just get this to go into, there we go. Excellent. Well, and it's such a pleasure to be here with all of you, and thank you so much to the organizers for including me, and for Dr. Buckley, it's a pleasure to co-present with her today. I'm going to talk a little bit about building off of what Dr. Buckley talked about, and where are some of those gaps in our understanding? Where are some of those questions? And how do we take maybe some of the large studies that we've seen and translate those into the next steps? And what does that look like? So you've seen a little bit of these statistics, and this is actually from an annual report that's published by the Alzheimer's Association called Facts and Figures, just in terms of the numbers of people that are affected by Alzheimer's and other dementia. And the number of women both living with this disease, but also those that are providing care, is quite expansive. And so we know that there's a greater burden of these diseases, Alzheimer's and other dementia, on women, and really understanding not only the, as Dr. Buckley talked a little bit about, are women more vulnerable in terms of having the disease? Are they at greater risk? What does that look like? Or are they living longer, and so they're maybe more resilient and progressing at a later point in time? But also the considerations around care and what that means for individuals, understanding that societal impact, the stressors, and some of those things as it relates to care, and how that may impact women in their overall health as well. So as you just heard, there's a lot of things that we don't completely understand. We know that there are more women living with this disease, but the mechanisms are not so well understood. There are things around our brain structure that you heard Dr. Buckley talk a little bit about where we might have some of these changes that we see in disease. And that's different. There's differences in the structure between males and females, including some of the networks and the processing structures. And that's all through development, as well as that wiring system of our brains. We talk a lot about it at young ages, differences between males and females in terms of development. Well, as we age, how does that difference in the development impact our brain, the overall network and the wiring of our brain? You heard Dr. Buckley talk about the genetics and the X chromosome and seeing these differences in terms of their impact. Apolipoprotein EE4, or ApoE4 is one of those genes that's been associated with differential risk between males and females in some populations. We don't necessarily see that in all populations. And so understanding why and what that means, and what's that intersection of sex differences, genetics, and environment as an example. Some of the metabolism mechanisms, and not the metabolism necessarily around our diet, although there's a tie in there, but more metabolism in terms of our brain's energetics, how our brain cells are making and producing food and energy products for every function. There are differences throughout life between males and females in our immune system. And what do those contribute in terms of the life course and risk around life course, or vulnerability around life course? Are there things that perhaps are increasing or decreasing risk in different populations? Very similarly, as we think about our vascular and cardiovascular structures, it took a number of years before we recognized that there were differences in perhaps those first warning signs of a heart attack between males and females. Well, do we see some of those same things when we think about our cognition? Are there differences in what those early warning signs may be, and how do we identify those? Dr. Buckley talked a little bit about menopause, as well as the initiation of menstruation, those hormonal changes throughout life. What are some of those considerations, and how do we understand both the association, but then translate that to something that is maybe more impactful in our understanding around, is there a cause and effect? Is there an intervention that could play a role? What does that look like? And of course, the other biological and social factors, I just mentioned a little bit about care, but there's also some of those things around risk, around stressors throughout life. What might be some of those contributors as we go forward? Now, this is adapted from Northwestern medicine, but it is just an indicator when we think about brains, when we think about the brain and thinking about the sex differences between males and females and what some of those contributors might be throughout life. So things, for instance, on average, the male brain is 10% larger than the female brain, but the female brain has more gray matter. So these are things that we know in terms of general assessments when we look at differences at a population level of some of those differences that may be present in the male brain and the female brain, and again, throughout life. So how does this contribute to across the lifespan in terms of either maybe women are more vulnerable to some of those changes, or perhaps we're able to stave them off for a longer period of time. And so then you see some of those brain changes and you see women are living longer, so you see them more present in the later stages of life. So an example of this association that we see, this came from, these were two studies, one that came out of Kaiser Permanente in Northern California and a smaller study that was also conducted in another population in the UK. But between them, over 14,000 individuals, females that are individuals that identified as female. And what we saw is that there were the individuals with longer reproductive periods, meaning an earlier age of menstruation and a later age of menopause, had a decreased risk compared to others. Women with 3 or more children had a decreased risk compared to women with 1 or no children. Total months pregnant, so not necessarily number of children, but total months pregnant, also seem to be associated in a dose-dependent way, if you will, with a decreased risk. And a history of miscarriage was associated with an increased risk. So understanding this in terms of these associations, how do we translate that to knowledge about what might be those contributions? For instance, having 3 or more children. Is there something about pregnancy? Is there something that happens during that period of time that there's changes in your vasculature, within your immune system, within your metabolism? There's something about that duration in terms of your nutrition. Or is it that women with 3 or more children are multitasking and balancing things in a unique way that is impacting their cognition long term? We don't know the answers, but it's that kind of question and how we interpret this information that's so important. And so how do we translate this to understanding the risk and ultimately with a way of intervening to mitigate that risk? So thinking about all of these biological pathways and how they contribute and really understanding them with this perspective of sex differences in terms of, for instance, the vascular system. Again, that comparison. We know that some of the early warning signs of a heart attack are different between males and females. So it would make sense that when we think about the vasculature contribution to our brain, our cardiovascular disease is intersecting with our brain in terms of blood in and throughout our brain carrying oxygen for every processes of our brain. So when you think about that, are there differences in that structure that may also contribute to our brain health throughout life? And that's just one example, but you can look at all of these mechanisms as well as others that are not on here to try to understand what those differences are. And this is incredibly important as we think about diagnosis. As we think about treatment, the combinations of those things may be different for a female versus a male, depending on other contributing factors throughout life. That idea of moving towards precision medicine, whether a male, whether a female, whether it's someone that identifies as in another way, ensuring that we're understanding their specific biology, what's contributing to their risk, and how do we intervene accordingly. There are many unanswered questions. I named a few right now, but some of these things around hormonal changes or changes in the DNA throughout life and the differences in biological sex, thinking about the sex organs in terms of their linkage with brain function measurement, some of these different biomarkers, the genetic links, the hormone system, our hormonal systems, the immune related, but so much more, but even just the network and the structure of our brains throughout life. And these are just some of those unanswered questions. And this is why one of the things the Alzheimer's Association is the world's largest nonprofit funder of Alzheimer's and dementia science, has made significant investments in trying to better understand these changes and seeding this research in how can we address it? How can we better understand it? And I'm excited that in just the next couple of weeks, we'll be announcing the next round of those awardees that are asking and answering, hopefully, some of those questions. Because as we think about Alzheimer's disease, we know that there's a lot of different biologies that are changed. We talk a lot about beta amyloid plaques and tau tangles, but those are really only 2 of the brain changes that we see in this disease. We have increasing tools such as the imaging that you saw from Dr. Buckley, but many others that allow us to look at what might be those individual changes and make an accurate diagnosis about what might be happening for an individual. But how do we ensure that we're doing that in all populations, males and females, but all representative populations? And ultimately, use that information as we think about intervention, whether it be with therapies, medication therapies, or thinking about how we address some of those modifiable risk factors. So while we understand that there's this difference, we understand more today than we did just 10 years ago, or even 5 years ago. We certainly have a lot of unanswered questions. And as we move forward in this new era of treatment in Alzheimer's and dementia diseases, understanding these differences will help only accelerate us even further. So really looking forward to the discussion today. And I see there's a lot of questions that have already come through, so looking forward to those.
Thank you so much. Again, this is great, and I invite both of you, Dr. Snyder and Dr. Buckley, to turn on your cameras as we enter this panel discussion portion. And those that are tuning in, the attendees, we invite you to submit questions using the Q&A function at the bottom of your screen. We will try to address as many as we can during the next about 8 to 10 minutes of the program. And I did want to note that our conversation today is intended for educational purposes and is not intended or implied to serve as a substitute for medical or professional advice. So we encourage all patients and consumers, please, to confirm information and consult with your healthcare provider to determine your individual needs. So to open this conversation, I'd like to start with expectations surrounding changes in cognitive function as we age versus signs of dementia or Alzheimer's disease. And so I know these two phenomena are often thought to go hand in hand, this expectation that, I will lose my memory or cognitive function. Can you please clarify that difference?
Yeah, I'm happy to talk a little bit about that. We hear this a lot. So one of the things that the Alzheimer's Association developed along with a panel of experts over the years is something called the 10 signs. So what are those 10 early signs that somebody may recognize in yourself? And you can find them at alz.org/10 signs. But really the idea to think about are what are things that are changing yourself? Whether as we age, we all have things that changes or that we notice, and that can be driven by a number of different factors that might be going on in our lives. And necessarily, like I drove to the airport this morning. I don't know where my car key is right now, but I'm sure it's somewhere in my bag. That's not unusual for me. I never know where my car key is, whereas my husband could tell you where it is at any given moment. I balance my checkbook every week. If that became something that I started to have an issue with, he's never balanced a checkbook. He couldn't do it 10 years ago. He's not going to be able to do it in 10 years. That wouldn't be a change to him. So something that you've done for a period of time and you start to notice those changes. But it's always good if you are concerned about anything going on in your cognition or your overall function or just in your daily life, have that conversation with your healthcare provider. Share that concern with them. Share what you're noticing. It may not be Alzheimer's or another dementia or some of those early changes. It may be something about a nutritional imbalance. It may be something around a hormonal imbalance. It may be a sign of sleep deprivation or something else. And so it's so important to have that conversation.
Thank you. I know we talked about different risk factors associated for women in getting Alzheimer's and what about the modifiable or lifestyle choices? I know you mentioned a bit of that. Could either of you or both of you give a little bit of insight? What are some of those lifestyle choices that might help to improve brain health? And if there's any studies around that might reduce risk for Alzheimer's?
I'll just jump in for a second, because I think that there is a very interesting area looking at women's health in association with modifiable risk factors, changing of lifestyle. And there's a couple of considerations here that I've been seeing emerging in the literature, looking at this idea of changing lifestyle around the age of menopause and thinking about what that might do to help alleviate symptoms, and also to just generally help with everyday sort of functioning and feeling better, quality of life, but also thinking about changing lifestyle later in life too. One of the strongest messages that I have, that I've seen so far from the evidence as it stands, is that there is no better time to change than now. If you are thinking about, well, maybe I should do a bit more exercise. Maybe I should think about changing up my diet. Certainly any of these changes at any point in a woman's life, particularly I think about women's health, is a good thing. Whatever is good for the heart is good for the brain. But I'll also hand over to Heather, because I'm sure she has a lot of thoughts on this too.
Yeah, I mean, I think you nailed it though, Rachel. When we think about, do more today than you did yesterday, that old adage of use it or lose it, continuing to engage your brain and your body in daily activities, whether it be social and cognitive engagement, physical exercise. Some of the strongest evidence is around the benefits of physical exercise. That's true for our overall health, but find something you're going to enjoy doing and you're going to stick to doing, and then you'll do it, right? But of course, before you take on any new activity, any new physical activity, you should definitely have that conversation with your healthcare provider about what that impact might be, and consider that within your life and within your lifestyle. But what we've also started to see is it's actually the synergy of perhaps some of these risk reduction behaviors. So we think about physical exercise, but how about pairing that with a balanced diet? Not unlike how we think about heart disease, right? So the kind of best interventions are thinking about how do we pair some of those interventions together. And there's actually studies going on right now in the United States. There's one that the Alzheimer's Association is a funder and leader with a number of incredible researchers across the country, called US Pointer, that's doing just that. It's enrolling individuals that are thought to be at an increased risk, looking at a very specific combined recipe interventions in a representative population across the United States to say, what's the impact on cognition? These individuals don't have Alzheimer's, they don't have dementia, but they're at an increased risk. And so we look forward to seeing the outcome of that information. But that's really built on a number of other studies that have informed that there's something to use it or lose it, do more today than you did yesterday.
Just relating to the US Pointer and other studies that are sort of associated, the thing I found so amazing and so exciting about those types of studies is that the largest engagement and recruitment is from women. Women are actively engaged and interested in modifying their lifestyle and the way that they live their lives, which is really exciting.
And so, there's things that we can do, and, there's, as that research is coming out, but even on the screening front, if you have, for example, increased genetic risk, or you may not know that, but that a family member, especially an immediate relative, an aunt, a sister, a mother, or more than one, has developed Alzheimer's disease, what does screening look like? Is that something that someone should now get screened or get assessed? Is there provision for that in the healthcare system?
Yeah, so, I think there's a couple different things there. So within the United States, for Medicare beneficiaries, there's the annual wellness visit that is part of an annual visit that you can do with your healthcare provider. And you can ask, if it's not automatically part of it, you can ask to have cognitive evaluation as part of that. Based on what we know, really that the context of having that type of evaluation in a medical setting is really the best way to go forward, so that you understand what that might mean. But it's also looking at how to assess that over a period of time. And so there is a provision for it in terms of the annual wellness visit for those that are Medicare beneficiaries. For those that are not, again, have that conversation with your healthcare provider and see if that can be part of your annual physical, or if that can be part of that. I will note though, I'm not the best at getting my annual physicals. So if we're being real, right, I'm sure that's true for many of you that are on this as well. And it's so important that, and I practice what I preach, that we should all really think about prioritizing our health, particularly as women that are often doing so many different things, and how do we balance that? So, have that conversation with your healthcare provider throughout, whatever age you are, because there's really, again, coming down to things around sleep, overall life stressors, and some of those considerations, and all of that can impact, our cognition and our function as we age.
I think there's also a personal element too when you think about the genetic risk, as I was referring to the ApoE4 gene. There's, I think, a lot of potential fear in the community of, if I know about my E4 status, what does that mean for me? And I think that there is a lot of considerations there. Certainly, it's still unclear in terms of knowing E4 status, what that means for insurance and those sorts of things. But at a personal level as well, what does it mean to know? And everyone will have their own decision. And I do agree also very strongly with Heather. Speaking with a primary care physician is so important when thinking about these matters. On my own level, I found out for myself, and so did my mother. We were very interested to know, and it did help us. We personally believe that knowledge is power, and it does help us to think about our future and how we want to sort of live our lives as fully as possible and in the most healthy way as possible.
And so to kind of bounce off of that, but offshoot, you talked about there's the role in women, of course, and there's biological sex, there is a role of hormones, but those are endogenous. So if you're dealing with what is the role that exogenous hormones, maybe hormone therapy plays a part, or individuals that might be taking other hormones for, maybe gender affirming or something like that. What role does that play in risk for Alzheimer's, if you have any updates on that research?
Well, it's a really great question, and one that is often asked of me at the moment, particularly because we just published a paper looking at hormone therapy in terms of Alzheimer's disease risk. At the moment, I think that the research is somewhat up in the air, but I think we do feel fairly confident on some facts. What we do know at the moment is women who do take hormone therapy, there seems to be a prime perfect window of opportunity of when you can take it and be at lower risk of deleterious outcomes like Alzheimer's disease dementia. There was a massive clinical trial called the Women's Health Initiative that ran a few decades ago, which showed that women who take hormone therapy much later in life to when their age of menopause was, say 15 years later almost, those women do seem to be at higher risk of dementia. But that was not all women. That tended to be women who were also showing higher rates of cardiovascular risk, potentially other risks as well. Diabetes was one in particular. And so I think that there are considerations that need to be had with a primary care physician, as we have been saying throughout most of this panel. And so hormone therapy is not actually as horrifically bad for every single woman at all. It really does depend. And certainly the data doesn't really seem to suggest that women who take hormone therapy around the age of menopause, they don't necessarily seem to be at greater risk. However, in saying that, there are lots of different formulations of therapy and different ways of taking it and durations. And so really talking to a primary care physician is so important in this matter. In terms of gender affirming medications, there really isn't a huge amount of data, and there really needs to be a lot more focused on this.
And so I know we're coming against time here. And so before we wrap up, just one last question. We often have patients and healthcare providers, as well as researchers and policy professionals, tune into our webinars like this. And so what is one takeaway that each of you would recommend to viewers to help them support research or screening or prevention for Alzheimer's disease in women? And so I guess if we start with Rachel and then end with Heather.
It's a great question. I think that the thing that I would really love to see and to hear championed amongst a range of different levels is advocacy, particularly for women's health. There's been a new dawn, I think, in terms of women's health research in Alzheimer's disease, but there needs to be so much more done. I think focusing targeted funding, just like the Alzheimer's Association are doing for sex and gender research, is so critical right now. Helping junior researchers to be able to get critical research off the ground is really important. Heather?
Yeah, I think there's so many, depending on where, somebody's lens, I think there's so much that we can all be a part of the solution. And some of it is whether it's advocating for increased resources at the federal level, whether it's advocating for things like the ENACT Act, which really looks to ensure representation in our trials of based on both biological sex, gender representation, racial representation, and ethnic representation. I think those are opportunities that we can all be a part of the solution. Volunteering for a clinical trial is certainly another avenue that we can take. I know I saw a couple of the questions that we didn't get to, that there are individuals that are interested, that may be interested in that sort of avenue. And so there's a lot that we can all do. Again, I think it's just continuing to use your voice with whatever your expertise and role is, and sharing your story, whatever that is, as well, to continue to raise the volume of this conversation in all communities.
Great. Thank you so much to both of you. You've been an amazing panel. Thank you for your time and for your insight. And to Roche for their support of this public forum and SWHR's Value of Diagnostics Within Women's Health series. SWHR will continue the conversation, #SWHR Talks Alzheimer's, in our work to promote research to better understand, diagnose, and treat Alzheimer's disease in women. You can learn more about SWHR's advocacy work and future plans in the Alzheimer's space through our policy agenda, breaking down the burden of Alzheimer's disease for women. Or join us for online events like this and in-person events like the Power of Research, Bridging the Gap luncheon we co-hosted with Maria Shriver in the Women's Alzheimer's Movement in April, or a symposium on mature women's health at the annual meeting for the Organization for the Study of Sex Differences last month. Alzheimer's disease is also one of our focus areas for SWHR's Women's Health Dashboard. Through this platform, you can explore the latest national and state data on diseases and health conditions that have significant impacts on women's health across the lifespan, including public health data, research investment in progress, health insurance coverage, and relevant policy implications and actions. And there is more to come in this month and on, hint, hint. SWHR is definitely looking forward to highlighting additional areas of women's health that benefit from innovations in screening and diagnostics. Our next event in this webinar series will focus on the value of diagnostic tools for screening and diagnosing lung cancer, held in November in recognition of Lung Cancer Awareness Month. We invite you to visit our website, www.swhr.org, to watch the recordings from this entire series of public forums. You can also connect with us on our website as well as on social media to register for future events, download women's health resources, and sign up for our newsletter. We will send out an email with a recording of today's webinar to all registrants, as well as post the recording on the event's webpage for future viewing. So please be on the lookout for that and feel free to share with others as we continue the conversation with #SWHR Talks Diagnostics and #SWHR Talks Alzheimer's. Thank you for joining us.